Continuing the recording, what is the procedure, education that should be followed step by step when administering blood products to patients? What does a patient need to sign consent? Administering blood products is a procedure that requires an order from a healthcare provider and begins with a thorough patient assessment and careful monitoring during and after the transfusion. Transfusion assessment includes ensuring the patient understands the reason for the transfusion and determining whether previous transfusions has been performed on the patient, especially if a transfusion reaction occurred as a result. Although they are usually at no greater risk for a reaction in a subsequent infusion. This may be a cause for anxiety. So we are obtaining. Before I start anything, I'm going to make sure that they have a signed consent. So we assess the baseline vitals. We explain the procedure to the patient, and we educate the patient. Educate the patient about the procedure and answer any questions they may have. Also instruct or teach the patient to report any side effects of transfusion, any chills, dizziness, fever, pain, difficulty breathing. Ensure that the patient has an informed consent. Know your agency's policy before initiating blood therapy. Verify 3 things for patient safety. The blood components delivered are the ones ordered. The blood delivered to the patient is compatible with the patient's blood type listed in their medical record. That the right patient is receiving the blood. 2 RNs must check the label with the blood product against the medical record and the patient's identification number, blood group, and complete name. Do not give any blood with any minor discrepancies. Contact the blood bank immediately. So if the numbers are slightly off, don't be, oh, it might just be a mistake. No, contact the blood bank immediately. Administer the blood as soon as it's brought to the patient. Don't refrigerate it on the nursing unit. If the blood is not used within 30 minutes, return it to the blood bank. Administration, ensure the presence of an appropriate size IV catheter and blood administration tubing that has a special filter is available. Adults, we use an 18 or 20 gauge needle. Blood is more viscous or thick, so you need the bigger needle. Another thing to think about with our with our catheter size, we want to use that larger bore catheter because we want to prevent the hemolysis of the blood or the red blood cells breaking up. Children with smaller veins need smaller catheters. Prime the tubing with 0.9 sodium chloride or normal saline to prevent hemolysis or RBC breakdown. Initiate transfusion slowly and allow for the detection of a transfusion reaction. The majority of our transfusion reactions occur within that first 15 minutes. Maintain the ordered infusion rate, monitor for side effects, assess vital signs, and record all findings promptly. Remain with that patient for the first 15 minutes of the transfusion. That's when a reaction is most likely to occur. Continue to monitor the patient and obtain periodic vital signs per policy more frequently and as needed for up to 1 hour after transfusion. How would you assess for a transfusion reaction and how would you respond? A transfusion reaction is an immune response to transfused blood components, which ranges from mild to severe. Transfusion reactions include mild reactions, febrile, non-hemolytic reactions, acute intravascular hemolytic reactions, and anaphylactic reaction. Prompt intervention is essential for life-threatening reactions. Mild reaction. Assessment, signs and symptoms, flushing, itching, hives. We stop the infusion temporarily. Give antihistamine as directed. If symptoms are mild and transient, restart the transfusion slowly. Do not restart the transfusion if fever, pulmonary symptoms, or hypotension develop. Febrile non-hemolytic reaction, signs and symptoms. Sudden shaking, chills, fever, headache, flushing, anxiety, muscle pain. Response: stop the infusion, give antipyretics as prescribed, avoid aspirin in thrombocytopenic patients, do not restart transfusion. Acute intravascular hemolytic reaction. Assess signs and symptoms: chills, fever, lower back pain, flushing, tachycardia, tachypnea, hypotension, hemoglobinuria, hemoglobinemia, sudden oliguria, so no urination, circulatory shock, cardiac arrest, death. Stop the infusion immediately. Keep the IV line open by replacing IV tubing down to the catheter hub with new tubing and running 0.9% sodium chloride, normal saline. Do not turn off the blood and simply turn on the sodium chloride, the normal saline that is connected to the wide tubing. This causes the blood remaining in the IV tubing to infuse into the patient. Even a small amount of mismatched blood can cause a major reaction. So we don't use the tubing that we're running the blood with, and taking it down to the catheter means we're even taking off that extension set, because we don't want that bit of blood that's in the extension set to run into the patient. Immediately and notify the healthcare provider or emergency response team. Remain with the patient, observing vital signs and symptoms and monitoring vital signs as often as every 5 minutes. Prepare to administer emergency drugs such as antihistamines, vasopressors, fluids, corticosteroids, as per healthcare provider order or protocol. Perform cardiopulmonary resuscitation. Save the blood container, tubing, attach labels, and transfusion record, and return to the blood bank. Obtain blood and urine specimens per healthcare provider orders or protocol. Anaphylactic reaction. Assessment, signs and symptoms. Anxiety, urticaria, dyspnea, wheezing progressing to cyanosis. Excuse me. Severe hypotension, circulatory shock, possible cardiac arrest. Stop transfusion. Have epinephrine ready for injection. Provide blood pressure support as ordered. Initiate CPR if indicated. Do not restart the transfusion. What are the primary complications associated with IV therapy? Primary complications associated with IV therapy include phlebitis, infiltration or extravasation, circulatory overload of IV solution, infection, bleeding at the puncture site. Line maintenance, aseptic technique, frequent assessment and monitoring of patients on IV therapy is essential in preventing complications. Identify signs and symptoms of IV infiltration and IV phlebitis. When an IV catheter becomes dislodged or a vein ruptures, causing fluid to enter the surrounding subcutaneous tissue around the venipuncture site. This is known as infiltration. When those fluids contain additives that damage tissue, it's known as extravasation. Signs and symptoms of infiltration include coolness, paleness, and swelling at the IV site. Skin around the catheter may be taut, or it's tight because it's full of the fluid, edematous, and painful. Because it is not entering the circulatory system any longer, infiltration also has the potential to stop or slow the IV infusion. Phlebitis is inflammation of the vein that stems from a chemical, mechanical, or bacterial causes. Risk factors include acidic or hypertonic solutions, rapid IV rates, certain drugs such as vancomycin, potassium chloride, and penicillin, insertion of an area of flexion, poor hand hygiene and aseptic technique, a poorly secured catheter, So in class we talked about like the inside of the vein getting irritated, and that could kind of cause the vein itself to swell and you end up with this phlebitis. So going back to what the Perry and Potter book said, so if we use an area of flexion, such as the AC, to insert an IV, that bending could have that catheter moving around inside and irritating the vein, increasing the risk for phlebitis. Also, a poorly secured site is also mentioned, and for the same rationale that the catheter could possibly be moving and irritating the inside of the vein. Signs and symptoms manifest through typical signs of inflammation include heat, swelling, pain, tenderness along the vein, a possible red streak or palpable cork or cord along the vein may be noted. This complication is particularly dangerous because blood clots may form along the vein and may cause emboli, potentially causing permanent damage. What needs to be documented about IV sites? So we are documenting the time and date of insertion, number and location of site attempts, precise description of the site, side, extremity, vein, landmarks, etc., catheter size, type, gauge, and brand, type of dressing and catheter stabilization, flow, and amount of infusion. If an electronic infusion device is used, patient response and condition, patency, integrity of system, overall status of venous access device, and myself, the person who inserted the IV. So we have our air in the line versus occlusion alarm. So if I go in the room, the IV is beeping and there's air in the line, or it's stating there's air in the line, it's just within that part of the pump, it's sensing air in the line. The only part that it actually senses the air is the part of the tubing that's actually within the pump. Versus if I get an occlusion alarm, the pump is sensing an occlusion alarm because the pump is trying to push that IV fluid through, but it's meeting resistance. So then that occlusion alarm will go off on the pump. So if I'm getting that occlusion alarm, something is preventing the IV pump from pushing that fluid forward. So the IV site might be lost. Like it may have slipped out of the vein and the fluid isn't getting pushed through the pump smoothly. The tubing might be pinched. A clamp might be closed, or it could be patient positioning. Like the patient might be somehow on top of the tubing to where it's smashing it enough to not allow the fluid to go through. It could be that AC site and the patient bent their arm and bends the catheter so it doesn't allow the fluid to go through. Red blood cells given to increase the oxygen carrying capacity of the circulatory system due to acute or chronic blood loss. Albumin given to replace volume after acute loss, especially in patients that have severe burns or developing signs of edema, known as a volume expander. Plasma given to correct coagulation deficiencies and or to reverse the effects of warfarin. So going back to warfarin, so if their dose is too high, their bleeding time or their clotting time is going to be prolonged. It's going to take them longer to clot. They're at a greater risk to bleed. So if we're giving plasma to reverse the effects of warfarin, what kind of labs might I see in my patient that indicate that my warfarin or Coumadin dose was too high? So we're going to look at our PT-INR. So if our INR is really high, that might be corrected through giving plasma or by giving plasma. IV considerations in the older adults or in the elderly, we don't want to use a tourniquet if we don't have to, just because of the risk of skin tears. We want to avoid using excessive amounts of tape. When we do get, and we might have to use a smaller catheter also. When we do achieve IV access in the elderly patients, we do cover that site with a tegaderm or a transparent dressing. But before we do that, we can use skin prep or some kind of skin protector to help reduce the risk of that when that tegaderm is removed of causing a skin tear. Use minimal tape to secure the IV extension set, or you can use like a stretch gauze to secure the IV insertion, the extension set. But we do want a tegaderm or a transparent dressing to cover the actual insertion site. How do you know the IV needle is in the vein and that you can advance the catheter when starting an IV? So, okay, we're going in to start the IV and you're piercing the skin and then eventually you pierce the vein. How do you know you're inside that vein? Well, you're going to see that little flash of blood in the flashback chamber, and then you know it's okay to continue to advance your catheter. What do you do if you get the exposed end of IV tubing, or what do you do if the exposed end of IV tubing becomes contaminated? What I mean by this is like you're starting an IV, like you have your IV tubing. We know we don't get that spike contaminated, that spike that we're puncturing our bag of either fluids or our secondary bag. And the end is the part that you screw into the needle-free port. That has a little cap on it. If that end gets, like if you touch it on the med cart, the patient's bed, the patient's arm, we can't just clean it with alcohol. We need to replace the whole tubing. So that's the part that screws into the needle-free port that screws into the extension set. So let's think about this. Let's say you were about to give an IM injection and your needle touched something. Do you just wipe that needle down with alcohol and continue? So that's just an example to help correlate. Like if that little tip of the IV tubing it touches something, you need to replace it. Just like if your needle or something touched something, you need to replace that also. When flushing lines, use a 10 cc syringe. So on the board, we wrote this down in class. Our smaller syringes can create too much pressure, especially for flushing a PICC line, and it could cause the tip to break off. And start IVs distally and work your way up. So like we want to start distally or like closer to the wrist and work our way up. Because once you start an IV in a vein, you can only work proximal. You can't start a new IV distal to a previous site. And that is it for this sheet.